Hello, and welcome to the CAP Today webinar for Tuesday, September 19th. Today's webinar is entitled Algorithms, the FilmArray Meningitis Encephalitis Panel, Experience of a Tertiary Care Children's Hospital. I'm Bob McGonigal. I'm the publisher of CAP Today, and I'll be your moderator today. I'll be leading a question and answer and comment section after all of our formal talks. Today's chief presentation will be given by Dr. Jennifer Dien Bard of the Children's Hospital of Los Angeles. I'll tell you more about Jennifer in a moment. But first, I would like to acknowledge that BioFire has made today's webinar possible through an educational grant. We've worked with them many times, and we're very glad to have them back here again. Before we begin the formal presentations, I would like to go over a couple of housekeeping notes. You'll be listening on your computers through your speakers. Should you have any problems technically, you can let us know by typing a question or comment in the Q&A box, which you'll see on your screen underneath the overheads. And you can make a comment or ask a question at any time during today's webinar. We'll deal with technical matters immediately to help resolve those. The substantive clinical and technical questions, of course, will remain for our question and answer session. It's important that you know that all the slides and the audio of today's presentation will be made available on captodayonline.com in approximately 5 to 7 business days. Let me say once again, thanks to BioFire, who have made this possible through their educational grant. It is important that you understand that the CAP Today does not endorse any products or services of whatever kind that may be named in the program today. And of course, it's important that I tell you that any comments or gestures of mine are my own personal ones today. They don't represent the CAP Today or the College of American Pathologists. And now it's a real pleasure for me and an honor for me to introduce Dr. Jennifer Dien Bard. She got her PhD from the University of Alberta. She's a fellow of the Canadian College of Clinical Microbiology and a diplomat of the American Board of Medical Microbiology. She serves as the director of the Clinical Microbiology and Virology Laboratory in the Department of Pathology and Lab Medicine at the Children's Hospital of Los Angeles, where she is also an associate professor of clinical pathology at the Keck School of Medicine at the University of Southern California. And she's one of the finest presenters in our field, so we're deeply honored to have her today for her main talk on algorithms, the FilmArray Meningitis Encephalitis Panel. Dr. Jenn Baird, you can begin when you're ready. Thank you so much.
Thank you, Bob, for that lovely introduction. I would also like to thank BioFire Diagnostics for inviting me to present on our experience with the Meningitis Encephalitis Panel at CHLA. Just going to move to the next slide. Okay. Just a quick disclosure, I am a consultant for BioFire Diagnostics and I do have existing clinical research contracts with them. I also wanted to do a quick acknowledgement to my microbiology fellow, Dr. Samia Nakash, who has played a key role in our assessment of the meningitis encephalitis panel in our patient population. The objectives for today's talk will be to discuss the algorithms and panel testing for meningitis and encephalitis, and to identify key operational issues that may be needed to be addressed prior to implementation. And then lastly, to discuss the impact of the meningitis encephalitis panel in a tertiary care freestanding children's hospital. The infections of the central nervous system continues to be a burden clinically as it is associated with high morbidity and mortality. A study in the Netherlands on approximately 1,100 episodes of bacterial meningitis have reported a mortality rate of 21% overall and up to even 30% in cases of pneumococcal meningitis. The significance of identifying an infectious etiology is directly linked to the fact that delays in appropriate therapy is associated with unfavorable outcome. This was demonstrated in a 2007 study that reported significant association between delays in antibiotic initiation and mortality. The investigators showed that patients with bacterial meningitis, where the start of antibiotics were delayed by greater than 24 hours from onset of symptoms, were 2.8 times more likely to have poor outcome, and the odds ratio actually increases to 11.19 in patients that present with altered mental status and a positive culture. It is a common fact that the overall mortality, length of stay, and associated hospital economics varies depending on the type of CNS infection that a patient has. For example, this table here shows the national hospitalization data that reveals that viral meningitis is the most common cause of meningitis at about 54.6%, but is associated with much lower costs per stay, length of stay, as well as mortality compared to bacterial causes and other causes of meningitis, such as fungal. The interesting thing about the data presented here, though, is that even in the cases of the bacterial and viral meningitis, there were a significant percentage of cases that were considered viral or bacterial unspecified, as highlighted here, where it was deemed to be either one or the other with regards to infection. However, there was no definitive identification of the pathogens. For example, 84% of all viral meningitis were considered unspecified. And of course, overall, there was also 17.2% of all meningitis cases that were deemed nonspecific. The absence of definitive diagnosis and etiology in many of the cases is due to the fact that there are a variety of limitations associated with current, more traditional diagnostic approaches. For example, culture of the CSF is rather slow, can take up to a couple of days or more, and the likelihood of recovering viable organism is low. And is highly dependent on the patient's exposure to antimicrobial agents prior to lumbar puncture. Studies have found that sterilization within the CSF can be very rapid and as early as 15 minutes for meningococcal meningitis and within a few hours for other pathogens. Latex agglutination, albeit fast, adds very little value with low sensitivity and specificity other than for Cryptococcus. The CSF gram stain is typically considered a stat test, and in our case, we aim to provide results within 1 hour upon receipt in the lab. However, the overall sensitivity ranges from 30 to 90%, and the utility of the test is still highly dependent on the bacterial load, the organism that may be present, and of course, prior exposure to antibiotics. And lastly, blood cultures usually accompanies the CSF cultures, but again, sensitivity can vary. Negative blood culture is not really a tool that can be used to rule out meningitis. If anything, it helps predict the outcome, as the presence of a positive blood culture predicts poor outcome in patients with CNS infections. So this table here is a list of all the targets of the FilmArray meningitis encephalitis panel. It includes 6 bacterial targets that are most common agents of meningitis in children and in adults, 7 viral targets, and as well as 1 fungal target, Cryptococcus neoformans gattii. The reason why we were interested in the panel at our institution was primarily really for the bacterial target, because we did understand the fact that we were likely missing a number of infectious cases where it was culture negative and there was no other option to provide a definitive diagnosis. And so that was kind of the key reason why we wanted to look at this panel. So prior to implementation, we discussed with the infectious disease team to determine what sort of approach or algorithm we would want to have in place. One requirement was that, and that was non-negotiable, was that every meningitis encephalitis order must be accompanied by CSF gram stain as well as CSF culture. And this is due to the fact that, one, the panel itself does not include absolutely every single pathogen that could be infectious or infecting the patient. And also, if you can recover, susceptibility testing is very useful. So our options for testing was to test any patient that was suspicious for a CNS infection, CSF samples only where we were worried clinically about an acute infection, The third option would be to test only in patients where we're worried about an infection, but the patient has already received antibiotics prior to a lumbar puncture. The fourth option would be to test only when the gram stains are negative, so likely your culture is going to be negative, but parameters are highly concerning for meningitis still. And lastly, to look at maybe only testing in cases where you have your first line HSV or enterovirus PCR test being negative, as well as maybe CSF cultures that are negative already. And then maybe you might proceed then to the meningitis panel. So looking specifically at option 1, this is something that was in theory reasonable for us to consider since our volume was not that high and we would be averaging about 1 to 3 daily. So it was in this case we were putting our trust in the clinicians to order the ME panel only in relevant cases. This approach, though, may be problematic in institutions that have a much higher volume, and some of these labs have opted for a test restriction based on the presence or absence of pleocytosis at a defined number of either 5 or 10 white blood cells. The second algorithm option to only test acute infection was not really something we wanted to even entertain, since a number of targets within the ME panel was also causes of chronic CNS infections. And also, it would be very difficult for us from the lab's perspective to determine what would be considered acute and chronic without having to look at the patient's charts. So with that, our options were to test all patients suspicious for CNS infections or to restrict based on one of the 3 algorithms listed here, so number 3, 4, and 5. This discussion happened in the spring of 2016, and at that time there really wasn't that much data to really support one approach versus the other. And so we opted for option 1 with the hopes that generating prospective data will allow us to make more of an educated decision in the future. So our process and implementation workflow includes testing only LP samples, so that excludes VP shunts or other samples obtained in other ways. It must order culture, that is non-negotiable. Testing is performed 24/7 since we do have a 24/7 lab. And we also included as part of a key indicator of quality project with a goal of less than 4-hour turnaround time. And from the reporting perspective, the positives are paged to the microbiologist on call, so that's myself or the fellow, and then the positives would be called directly to the provider. So the next few slides, I'll be presenting data that we've compiled from clinical testing, and in total, we've tested over 300 samples thus far. Data available on 266 of these patients show a pretty even breakdown of male versus female with a mean age of 6.1 years. Approximately 70% of all these patients are presenting to the ED initially, and about half of the patients have an infectious disease consultation. Not surprisingly, the majority of the patients are located in the general pediatric unit before or even after implementation, and regardless of whether there is culture ordered alone or culture order in conjunction with the ME panel. And in the figure to the left, you can see that about half of the previously healthy patients were previously healthy, and about 10% were less than 7 days old. And so we separated this also to technically they're not old enough to have a significant past medical history. And overall, about 50% of all of our CSF collected have a FilmArray ME panel ordered, which kind of alleviated some of our concerns about test utilization or overutilization. So if only C. diff testing was something as easy to control, but that's, I think, a whole other talk. Data from 135 patients demonstrated a variety of signs and symptoms, specifically focusing on the clinical triad. About 50% presented with fever, and about majority of which were from infants. 30% presented with altered mental status, and then another 7% or so presented with some sort of neck stiffness or pain. There were also 7 patients that presented with acute flaccid myelitis in the summer and fall of 2016, and in those cases, the ME panel were negative as expected. As I mentioned, the turnaround time was one of our key indicator of quality metric, and data from July of 2016 to July of 2017 demonstrated an average turnaround time of 3.1 hours. And you can see from this chart to your left that in the past month of July, the average was actually 2.1, which I think is quite excellent considering it takes an hour to run the test itself. Looking at the frequency on your right of when the results were actually reported, the majority of the cases are reported within 2 hours and then followed by 3 hours. We next wanted to compare the prevalence rate of routine culture in the ME panel in 312 patients tested so far. The ME panel had a positivity rate of 14.4%. There were 45 individual patients that were positive and 48 targets. 3 of the patients had a co-infection, 2 with strep pneumoniae accompanied by an HHV6 and an E. coli K1, and then the last one was an enterovirus accompanied by an HHV6. The percent breakdown was 25% bacteria and 75% virus, and we had no cryptococcal cases since going live. The figure to your right illustrates the number of positives within each target, with the most common target being enterovirus followed by HHV6, but there were small clusters of bacterial targets that were also identified. Focusing specifically on the bacterial positives, there was a total of 11 ME positives at a prevalence of 3.5%. I'm comparing this to what was found in culture. There was actually only 4 culture positives identified at this time, 2 of which was a group B strep and 2 was strep pneumoniae. As a site that utilizes the FilmArray trend software, we were also able to monitor the prevalence and distribution of the pathogens over time as indicated in this figure. It's a useful tool for us to observe the epidemiology within our patient and to determine any abnormalities within the months of testing. So overall, when comparing all standard of care testing prior to implementation of the ME panel to results obtained by the ME panel alone, we identified a much higher detection rate of pathogens at 15.3% compared to 3.6%. The majority were viruses, but there were also increased detection of bacterial pathogens, including specifically strep pneumoniae and Haemophilus influenza, compared to the standard of care testing alone the previous year. To address the potential restrictions that could be placed on testing alone, we wanted to determine whether abnormal CSF parameters significantly correlated with a positive ME panel. The figure to your left demonstrates that yes, indeed, it was significantly more likely for CSF that was positive by ME panel to have one or more of the following: pleocytosis, abnormal glucose, or abnormal protein. And on your right, looking specifically at the 45 positive patients, we also identified that CSF with a positive bacterial target was more likely to have abnormal CSF parameters compared to viral pathogens. It also demonstrates, however, that in some cases of viral and bacterial CNS infections, the CSF parameters were completely benign, and using the parameter as a criteria for testing may be problematic in some incidences. Lastly, we wanted to determine the overall impact of the ME panel on antimicrobial usage and appropriate modifications. Looking at the first 135 patients that we've tested, we determined that the percent patient that had antibiotic discontinued, we determined that about 5% of all patients with a negative ME panel had antimicrobials discontinued within 1 day. Similarly, 0% of the patients that were positive for bacterial by ME panel had antibiotic stop, which is something that you want to see. In contrast, about 45% of all patients with viral target detected had antimicrobials discontinued within 1 day. Next, we wanted to have a closer look at the 45 patients that were positive and how the results directly impacted antimicrobial optimization. So focusing on the middle column, about 73% of all patients had antibiotics changed within 1 day of report when a bacterial target was detected. And then the remaining 3 patients did not require any change in the regimen at all. And then when you look at the viruses on your right-hand side of the column, about 53% of patients had antibiotics discontinued within 1 day, an additional 24% of patients between 1 to 2 days. So overall, including the 4 that required no change, as in the patients were not exposed to antibiotics, there was 88% of patients that had antibiotics discontinued within 2 days of the ME result. So the remaining of the time, I will be providing case examples of our findings since implementation and how it may impact our decision to implement some sort of testing restriction that I mentioned. And so this was restriction number 2, 3, and 4 listed here. And so the first case that I want to present, and this was actually our first case that we tested ever, so it was a great start. It was a 23-day-old male that was transferred from an outside hospital with presumed meningitis. Primary signs and symptoms included fussiness and fever. The CSF parameter was very abnormal with elevated whites of 1800, low glucose, high protein. CSF culture was no growth, and unfortunately, a CSF gram stain was not performed at that lab. The patient, it was very suspicious for bacterial meningitis, and the mother's group B strep status was also unknown at the time. The patient was transferred to CHLA for further workup. We repeated the LP. There was also pleocytosis, low glucose, high protein. I forgot about the antibiotic course. The patient was empirically placed on ampicillin and gentamicin at the outside hospital and then switched to ampicillin and cefotaxime at our hospital to cover more broadly for gram-negative organisms. The patient was treated for suspected bacterial meningitis, and the primary suspect was group B strep. CSF culture, unfortunately, was no growth. Our gram stain showed many PMNs, but no bacteria seen. The HSV PCR was negative, and the enterovirus PCR was negative. And overall, this took about 48 hours because of the culture. The PCRs were available within 24 hours. During ID rounds, we were discussing this case, and I offered to run the ME panel, and this was actually communicated during rounds, and what was detected was Listeria monocytogenes within 2 hours from the discussion that occurred during ID rounds. And so the patient was definitively diagnosed with listeriosis and switched to ampicillin and gentamicin due to the fact that Listeria is intrinsically resistant to the third-generation cephalosporins. So this was a great example of a rapid test that provided a definitive diagnosis as well as allowed for optimization of therapy. The second case was a 19-year-old male with a history of recurrent bacterial meningitis due to traumatic event at the age of 3. Most common organisms that have been identified in the past were Strep pneumoniae, and the patient at this point in time presented to the ED with severe headache, fever, photophobia, and neck pain and stiffness. He was placed empirically on ceftriaxone and vancomycin. So the exam showed he was febrile, elevated, very abnormal CSF parameters again, so a very elevated white blood cell, a mix of 48% PMNs and 49% lymphocytes, high protein, low glucose. Microbiology workup, blood cultures were negative, gram stain saw many whites but no organisms, and the CSF culture was negative. So again, upon discussion with ID, we offered the ME panel, and Haemophilus influenza was reported to ID in around 2 hours. Vancomycin was discontinued, and the patient continued on the 3-week course of ceftriaxone. And since this was the first Haemophilus influenza case that we had in our lab, we decided to confirm with a alternate PCR and sequencing of the L-fucosyl gene, and it was confirmed to be Haemophilus influenza. So in this particular case here, the 2 cases I presented are prime examples of why we feel that restricting testing on only patients with prior exposure to antibiotics would not be feasible, as both of these patients had no exposure to antibiotics prior to LP. So restriction based on this alone may result in missed cases of true bacterial meningitis. So the next case, so case number 3, is an 11-year-old male with no significant past medical history presenting to the ED with seizures. Symptoms started in that evening. So there was fever, 1 episode of vomiting, followed by shallow breath. He did have a sick brother who had fevers and sore throat the past few days prior. And acyclovir, ceftriaxone, and vancomycin was ordered on the patient. So on exam, he was febrile. The CSF parameter was very benign, no white seen, protein was normal, glucose was normal, blood cultures were negative, and the CSF was completely negative from culture as well as gram stain. The enterovirus PCR was ordered at about 1:30 in the afternoon. However, it's only performed once a day in virology lab, and so would have been tested the next day. With that, we opted to set up the ME panel, regardless, despite the fact that it wasn't ordered. And the result was available in 3 hours or so, and enterovirus was reported. Of note, the NP swab was also positive for enterovirus for this patient. So the key thing here is that acyclovir, ceftriaxone, and vancomycin was actually canceled before it was even infused. So this, resulted in complete avoidance of unnecessary antibiotics in this patient. And the result, of course, was available about 20 hours sooner than it would have been if we had waited to set up the enterovirus PCR the next day. So case 3 is an example of why restricting based on gram stain negative, but other parameters may be concerning for meningitis due to the fact that you may see a complete benign CSF parameter in cases of viral or even bacterial CNS infections. So I briefly commented on this in one of the earlier slides, where true CNS infection does not always correlate with abnormal CSF parameters. So in a study that was published in Pediatrics in 2006, they looked at the correlation among CSF cultures and CSF parameters, and they stated that no single CSF value can reliably exclude the presence of meningitis in neonates, and that neonatal meningitis frequently occurs in the presence of normal CSF parameter. And this can be argued to be applicable to older children and adults as well. In fact, the presence of low CSF and white blood cell count has been reported to correlate with unfavorable outcome in cases of meningitis compared to CSF with high white blood cell count. In the table here, a low white blood cell count was associated with only 5.4% favorable outcome compared to 55.6% when the white blood cell count was between 1,000 to 10,000. The odds ratio for low white blood cell and poor outcome was reported at 3.43. So case number 4, this is an 8-year-old male with a history of ALL, status post-BMT in 2014, presented to the ED with fever, headache, body ache, and fatigue. He had a cough and rhinorrhea last week and had also had bilateral leg pain 2 days prior. The blood culture was collected on day 1 and was positive after 5 hours from collection and was reported as gram-positive cocci from the gram stain. The Virology assay from the positive blood bottle was performed and and Streptococcus species was detected. So this would rule out group A strep, group B strep, strep anginosus, but not necessarily strep pneumoniae. An LP was performed that evening, and on day 2 at 2 a.m. in the morning, so about 2 or so hours after the LP was conducted, the gram stain revealed few white blood cells, few gram-positive cocci, and rare gram-negative rods. Identification from the blood culture occurred on day 2, so about 22 hours or so from the time of positivity, and it was reported as strep pneumoniae. And the CSF culture was positive and reported as strep pneumoniae as well on day 4, so about 2 or 3 days after positivity. So the key thing is that the meningitis panel was also ordered on this patient, and it was actually positive for strep pneumoniae as well as E. coli K1 at 2 in the morning, so about 3 or so hours after the LP was conducted. And the patient was switched to cefepime about 3 hours later. And this, if you look at the timeline, was actually before even the identification of strep pneumoniae from the blood culture occurred. So with this case, in this patient, having a restriction of, testing a standalone HSV or enterovirus PCR first before proceeding with an ME panel, or waiting for a CSF culture result before proceeding with the ME panel, would have certain limitations. The culture was positive, of course, but you're waiting 2, 3 or so days just to get a result when you can have a rapid result within a couple of hours. And for cases like this, time is of the essence. The one concern that has been raised about the ME panel is the inclusion of certain viral targets that may be detected due to reactivation or, in rare cases, chromosomal integration of HHV6. The concern is that patients may be misdiagnosed with the viral process and exposed to unnecessary antibiotics. It is recommended that laboratories include a disclaimer to highlight this and to emphasize careful correlation with clinical findings. Looking at our data, of the 312 patients tested thus far, 12 were positive for HHV6, so an overall prevalence of 3.6%, which is actually higher than the 1.4% that was found during the clinical trials. When we took a closer look at the 12 patients, we found that 2 were also positive for other targets, strep pneumoniae and enterovirus, so the HHV6 results was considered insignificant in this case. One patient was presented with true signs of CNS infection, and an MRI actually showed leptomeningeal enhancement, and so the HHV6 positive fit the picture. The patient was diagnosed with HHV6 meningoencephalitis and treated with ganciclovir. 2 other patients were treated with ganciclovir for 1 to 2 days until it was deemed unnecessary and was discontinued. And then all other patients, so 7 others, were not treated for HHV6 at all, and because it was considered insignificant, and overall antibiotics were discontinued in these patients within 3 days. Okay. Let's see. So in total, there were only 2 out of the 12, so about 16% of cases where that were exposed to 1 to 2 days of unnecessary ganciclovir therapy. Importantly, though, there was a diagnosis of HHV6 meningoencephalitis that was made based on the ME result, and likely the case would have been missed if traditional standard of care testing was only offered. CMV is also associated with reactivation, and the same caution should be placed upon detection. Luckily, we have not encountered any issues with CMV detection, with only 1 positive CMV patient so far. And in fact, the ME panel led to the fortunate diagnosis of a CMV retinitis in an immunocompromised patient. Specifically, this was a 14-year-old male with ALL that was currently on maintenance chemotherapy. He presented to the ED with 2-day history of headache and back pain, and a FilmArray was ordered, and CMV was reported within 2.5 hours. Additional viral studies was performed on whole blood and urine, and both yielded positive viral loads of CMV. The patient was placed on a 5-week course of ganciclovir. The interesting part, though, was the fact that the positive CMV detected by the ME panel prompted an ophthalmology exam where a left-sided CMV retinitis with left-sided superior visual deficit was identified. So in the end, the patient was diagnosed with both CMV meningoencephalitis as well as CMV retinitis. The other concerns raised about the ME panel is the risk of contamination and misdiagnosis associated with this. This is by no means a secret, really, and it's even mentioned in the ME package insert with a comment that states that due to the sensitive nature of the FilmArray meningitis encephalitis panel, it is important to guard against contamination during collection and testing. The targets that are most concerning due to the fact that it can be commonly shed from healthcare workers are strep pneumoniae, Haemophilus influenza, and HSV1. Therefore, meticulous handling of specimens upon arrival in the laboratory is extremely important. Other recommendations include dedicating a BSL-2 cabinet for molecular testing or for ME testing alone if you have the resources for that, and this could really help alleviate some of the contamination risk. Also, having a well-defined decontamination protocol is recommended with emphasis on cleaning of surrounding areas before and after testing. And then, of course, changing gloves as often as possible, and consider dedicated lab gowns specifically for the ME panel. So in incidences where you do question a positive result, there are some approaches that you may consider to help rule out potential contamination. Gram stain, for one, to visualize the presence or absence of organism. Also, CSF parameters is another item to look at. Are the values abnormal? And if it is so abnormal, can it help determine between a viral or a bacterial process? However, to reiterate what I said earlier, these factors are important to assess as part of the investigation, but a negative gram stain and the absence of abnormal CSF parameter does not necessarily rule out infection. So that's something you have to take into account. Other factors that may be helpful is to review clinical charts and the patient's presentation, as well as radiographic findings. We have also adopted the approach of repeat testing on a case-by-case basis, but, I have mixed feelings about this, and there's issues that's associated with it as well. For example, if upon repeat the target in question is undetected, does that really mean that it truly is negative, or that it truly was a contaminant that happened the first time, or was it a weak positive that, due to sampling variabilities, cannot be detected again? And so that's, something that you kind of have to take into account when you consider repeating these tests. And of course, something that is also not uncommon for us being at a children's hospital, we have limited sample volume of CSF, and which may prohibit repeat testing. So we've been quite fortunate, knock on wood, at the hospital here, where our contamination rate has been very low. Of the 312 that we've tested and the 45 positives, 2 of which were considered potential contaminants. One was Haemophilus influenza and one was a strep pneumoniae. So the overall rate was less than 1%. Confirmatory testing performed on the initial 36 positives that we identified revealed that 61% were confirmed by an orthogonal testing. On the other hand, only 14%, so 5, were undetected, but one of the 5 we actually considered an actual contamination, which was the Haemophilus influenza. We were unable to confirm 25%, so 9 of the positives, due to insufficient volume. The 2 contaminants that I've mentioned is highlighted here. So with regards to the false positive cases, just a quick summary on how we approached it. The first was a 4-year-old male with no significant past medical history, transferred from the outside hospital with 2-day history of acute ataxia and vomiting. The FilmArray reported out as Haemophilus influenza, and this was early on, so unfortunately it was done even before and not paged to the microbiologist on call. Ceftriaxone was initiated 30 minutes after the ME results. The patient was pretty normal per se. There was no fever. The CT and MRI showed absence of meningitis. CSF parameters was pretty normal with regards to protein and glucose, with a slight elevation in white blood cell with a lymphocytic predominance. From the investigation side, we reviewed the charts, discussed with the clinicians, and we both agreed that the findings was really not consistent with the bacterial meningitis process. We did repeat the ME in this case, and it was negative. And due to the fact that, with agreements with the clinician, we did truly feel that this was a false positive. We did correct the report to not detect it. Ceftriaxone was discontinued, and the patient was discharged the same day with a diagnosis of ataxic gait, and was not seen again in our hospital within the next recent times. The second false positive was a 5-year-old male with no significant past medical history, presenting to the outside hospital with abnormal movement and crying. Transferred to Children's Hospital LA along with the sample in hand. I believe the parents actually brought the sample to the ED with them, which is, a little concerning and raises the questions for institutions of whether they really want to accept samples that you had no idea where this came from. And so it was kind of, it was a tough decision for us, but we did decide that because it's such a precious sample and it's from these children where we may not be able to obtain an additional LP sample, that we would accept them with, of course, the acknowledgement that there may be, of course, increased risk of contamination, and we likely will be including a disclaimer for each one of them. Unfortunately, this reported out as positive for strep pneumoniae. I was paged about this over the weekend, and looking at the patient's chart, the patient did not have a fever, but they did have active seizures during exam. It was a very bloody tap with a lymphocytic predominance. The protein was elevated, but the glucose was normal. And on investigation, again, I reviewed the chart, discussed with the ID clinician that was on call over the weekend. We both agreed that this really wasn't consistent with bacterial meningitis. However, it could not rule out meningoencephalitis in this case, particularly due to the age of the patient. And we were unable to repeat the ME in this case due to insufficient volume. And so with that, they proceeded on to treat with ceftriaxone and vancomycin as a precaution. And at the time, they were unable to perform a repeat LP due to a hematoma. We did report with a disclaimer that states to interpret results with caution. Integrity of the sample received in the lab may be compromised, that it is unknown how the sample was obtained and handled prior to receipt. Contamination cannot be ruled out as strep pneumoniae as part of the normal respiratory flora, and of course we recommend ID consultation. And the one other issue I wanted to raise is concerns associated with HSV-1 and false positivity, which was based on findings from the clinical trials, and more recently, concerns with the false negative results. This is a table here summarizing the current data available from publications and poster presentations, comparing performance of the ME panel in an alternate HSV-1 method. The blue text corresponds to false positive findings, and the red text corresponds to false negative. The multi-center trial reported 2 false positive samples that were likely due to contamination, since these were remnant samples that were enrolled in the study after completion of standard of care testing. So that was the first row. The other false positive was identified at Colorado Children's Hospital, ended up being a true positive based on clinical correlation. Regarding the false negatives, the one that was missed by Hammer and group had a CT value of 38 and so was deemed a weak positive. And the other 2 false negatives was from CHOP, and both CT values was greater than 35. However, of note, these samples were centrifuged prior to testing, which deviates from the recommended protocol of the ME panel. So in total, out of the 2,533 samples tested, there were 3 false positives, 1 true positive that was missed by standard of care testing, and 2 false negatives. And this slide that was generously provided by Dr. Amy Lieber summarizes the LOD study that she conducted at Nationwide Children's Hospital. The ME panel was compared to homebrew PCR assays in her lab. And so for the most part, the 2 assays compared quite favorably, but specifically for HSV-1, the LOD for the ME appeared to be comparable, if not better, than the homebrewed assay, where dilution by 100 and 1,000 continued to yield positive results by the ME of 2 out of the 5, but was undetected by the homebrewed assay. So the data provided here, as well as on the previous slide, really highlights the fact that analytical sensitivity is extremely dependent on the performance of the comparator assay, and so it's important for each institution to assess the performance of HSV and other targets, of course, as well as part of the verification study conducted prior to implementation. So this figure here illustrates, again, to reiterate the low viral load that may be present in the CSF itself. The red line is the analytical limit of detection, and the green bar is the patients detected during the clinical trials. And so you can see it's not uncommon for actual detectable viruses to be below the limit of detection. And as in the case of HSV-1, it also highlights the potential variability in results due to, as in the case of HSV-1, you can see that the detection was well below the limit of detection. The results here really highlights the fact that there's potential variabilities in results due to sampling errors. And as I mentioned earlier, the limitations in repeating the test to help rule out false positives is, present, and it's something that to really consider when you want to determine whether you should be repeating a test or not. And also, therefore, in the cases of HSV CNS infections, there's caution against depending solely on CSF results to rule out CNS infections in very young infants. And if anything, it's recommended that blood samples also be included to rule out HSV infection in this group. So based on the data that we have so far, we actually have no concerns with regards to HSV sensitivity in our institution. Taking a look back at the patients that we tested since going live with the test, there were 32 patients that also had a direct HSV PCR ordered. 30 out of the 32 were confirmed negative by both methods, and one patient was positive for HSV1 by both methods. An additional HSV positive case was detected by the ME panel alone, but upon repeating on the direct HSV PCR method, it was able to detect HSV1 at a CT of 39.8, so extremely weak positive. We also looked at 56 patients with ME testing that also had additional HSV PCR performed in alternate sources such as blood and lesions. And of the 56, 4 were positive for HSV1 from lesions, but were negative by both the ME as well as the HSV1 direct test that we have. So again, this helped alleviate concerns over suboptimal sensitivity of the ME panel, at least in our hands, compared to a standalone HSV PCR assay. And so to the point where we do reject orders of HSV standalone PCR that's ordered alongside the ME panel. So lessons learned so far in the year or so that we've performed this test, in the laboratory, it is extremely important to emphasize proper molecular techniques throughout. I think if you have the resources to be able to notify a microbiologist on call prior to reporting results is key, where we can, look at the patient charts, discuss with the clinicians, look at other lab findings prior to reporting. And then repeat when appropriate, but of course that comes with its own issues. From the provider side, it is extremely key that communication with provider is continuous and ongoing, particularly in discussions with positive cases. And what we found in our experience is that clinicians do actually act on the results provided from the ME panel, which is promising, considering it is a lot of effort for us to provide this 24/7, and also, of course, it comes with a cost. So for now, our no restriction approach appears to be quite reasonable, and it's something that will continue until we find or gather more data to determine otherwise. And so, in summary, implementation of the FilmArray ME panel have increased the rate of bacterial and viral detection from CSF in our institution. Be aware of the contamination risk associated with the panel, so proper decontamination and aseptic techniques can minimize the potential contamination rates. Overall, meticulous lab practice, clinical correlation, and clinical judgment is essential to avoid misdiagnosis. And we do need outcome studies to really determine optimal approaches specific to each institution, but also the overall impact of this rapid FilmArray ME panel on overall patient management and outcome. And with that, I will turn it back to Bob.
Dr. Dien Bard, thank you so much. That was a comprehensive and rich presentation. I enjoyed it enormously, and I know our audience did. I want to thank you for that. I'm going to give you a chance to catch your breath. And if we could go back to the first slide here, I'll come back to it, to our cover story. Let me remind everyone again that this entire presentation with slides and audio will be available at captodayonline.com in approximately 5 to 7 working days. And I know we're close to the top of the hour, but we have a few questions, and with your indulgence, we'll go a little past the top of the hour, and we'll go through some of these as soon as we can get there. First, because we already raised a question of clean rooms, and you did mention, Jennifer, contamination as being an issue, Would you like to answer this question of, does this require a quote-unquote clean room?
I completely agree with what Wade said. This is kind of a closed system, and, for the purpose of many labs that do not have specific clean rooms dedicated just to molecular testing, I don't think it's really necessary. We actually do not have dedicated clean room. We have a dedicated area within our microbiology lab where we perform molecular testing, and we also have a dedicated BSL-2 hood that we use for the FilmArray as well as other molecular testing, but definitely not a clean room.
Thank you very much. And just a quick follow-up to that, do you do some particular in-service to staff that may be collecting these samples?
We actually did not do any sort of in-service for the actual LP itself and collecting, or?
Yes.
Yes, so no, we didn't. We actually did not perform any sort of in-service. We've not really had, even from the culture perspective, encountered many issues with contamination from the collection process. So it wasn't something that we deemed necessary. However, if we had identified a high rate of contamination that did not rule out, potential contamination during collection, that would have been something that we would have pursued. But so far, we've been pretty lucky.
Of course. And let me follow up. There's several questions about your protocols and your current protocols. Just to be clear, you are now offering the ME panel without restriction, and you would imagine that would now become your standard of practice at the Children's Hospital?
Correct. We have been unrestricted for almost a year and a half now, and we will continue to do so unless we start to identify issues with that.
Very good. Thank you. So let me get to some of the specific questions here. Again, going back to your data that you presented that was so rich, do you correlate the ME panel results with gram stain and CSF profile? And if so, what do you do when you've had discrepant results? And then do you ever repeat your ME panel on positive samples? And if so, when or in what circumstances?
So that's a good question. So we do. For all positives that's paged to us, we do review the gram stain and a CSF profile to determine whether there's any sort of discrepancies identified. We also look at the chart review and the clinical signs, the patient signs and symptoms. Do we ever repeat? We do, and it comes with certain limitations, as I mentioned during the talk, of what that actually really means. But I have to say that for all positives where we were questioning, we have repeated. Mind you, the ones that have come back negative sometimes, it still did not necessarily result in us reporting it out as a negative, just because, you do have that sampling variability and it might have been a weak positive. So sometimes I find repeating almost raises more questions than it's actually helpful.
I can understand that. Your case number 1 fascinated a lot of people in addition to myself, and we had one questioner who asked, in this case, was there any other information gained that supported the diagnosis of listeriosis?
So that was, it was actually a really surprising answer for us, too, when we first looked at it, because we were just suspicious of Group B strep. When we went back to the parents itself and the history, if there was any sort of exposure, there wasn't anything definitive. We unfortunately did not have enough sample to confirm by PCR or sequencing, but due to the fact that it's, it was a neonate, the fact that the likelihood of it being a contaminant is so rare with Listeria that we felt that it was, we were pretty confident that it was a true case. We also sent the data to BioFire to have a look at, and there were no red flags identified on their end. And if anything, it was likely just a weak positive that came up.
Thank you. Now, you did mention reactivation, and we've got several questions on that. So could you please define for us what you mean by reactivation in the clinical case here?
Just reactivation specifically with HHV6, where, most people over the age of 2 have been exposed to HHV6. And so with secondary infections or so, you may see a reactivation occur where there's a presence of HHV6, but it's actually not the cause of the infection at the time. And so the concern is that if you're detecting HHV6 in a variety of these patients, that it may lead to unnecessary therapy, as well as it may misguide you or prompt like a stop in investigation for other sort of etiologies. So that's the one thing about HHV6 that has raised concerns with many people.
Thank you. Thank you very much. And here's a question that I know will interest almost all of us here on the webinar today. Have you ever had an incident where the patient was started on antibiotic therapy prior to the lumbar puncture so that the CSF results were negatively affected? That is to say, they may be disguising a bacterial infection that's at a low count, but may bloom afterwards if the initial gram stain was negative.
Mm-hmm. Oh, yes, because an LP sometimes takes time, especially in some of the younger children, and so they will not necessarily delay therapy just until they obtain the LP itself. So it's not uncommon at all for us to have samples received where the patient was already exposed to antibiotics, which is, again, one of the reasons why we thought this panel would be extremely useful in our institution with regards to the bacterial side of the targets.
Yes, thank you. Now, we know that the wise use of antibiotics, both as a clinical medical matter and as a financial matter, weigh on all of us who are involved in the field. Are you looking at trying to quantify your potential savings on antibiotics that would be made possible by using the ME panel?
That is something that we're at least documenting right now as part of an outcome study that we're currently working on. So myself and Samia and Nakash, and so we're looking at the discontinuation or avoidance of antimicrobials, and with that we can also add a number to the cost of each antibiotics. Depending on the antibiotics, it's not extremely expensive. Like even for example, acyclovir is not the most expensive of antimicrobial agents, but overall, we're including that. We're also going to be looking at potential length of stay and any decreases in length of stay that may be associated with running the ME panel.
Yes, that's a very good answer and a very good issue also to raise. So thank you for that. We have a question here. If Wade, you're standing by, you had indicated about the panel having a 94% sensitivity. We had a question here. Do you have sensitivities for each of the organisms on the ME panel?
We do actually. That's a requirement for FDA clearance. We have to look at each individual analyte individually and determine clinical sensitivity and specificity. And I won't on this call go through each one line by line and all the caveats that come with it and the 95% confidence intervals, but I will say generally they range from the low 90s to 100%. And if anyone out there is interested in seeing the sensitivity and specificities for each organism, feel free to contact any BioFire representative, and we can get you a copy of our package insert, which reports all that data with all the appropriate caveats.
Thank you. And now back to Jennifer. How often have you seen having a positive result with the ME panel when the CFS seemed to be completely normal from a biochemical workup?
Not too often. The example that I had with the false positive was probably one of the few. Otherwise, for the majority of it, they have had some sort of abnormal parameter. But that being said, it's not 100%. So we have seen, a one or two or so cases where the CSF parameters were completely normal.
Thank you. And finally, we know that you are getting orders from all kinds of folks there at the Children's Hospital. What is your protocol for addressing co-orders of monoplex PCR, for example, HSV PCR, along with the ME panel? How do you deal with those orders as they come in?
That's a good question. And so, unfortunately, there's no automatic way for us to control, what's being ordered and what's not. So we do try to be as diligent as possible to catch these repeat orders within the lab itself. So, for example, if an enterovirus PCR is ordered alongside HSV PCR alongside the ME panel, we will cancel the other two and run just the ME panel.
Good. Thank you. I have one more question here about the samples. Do you have any reservations in your children's hospital about test performance in traumatic CSF samples?
From where, sorry?
What this question is asking about traumatic.
Oh, traumatic CSF? We have not, it's unfortunately not uncommon for us to see a bloody tap. To have a bloody tap and a very bloody sample come to our lab. So far, we have not had any issues or concerns. You would think that if there was some sort of inhibition that's occurring within the sample itself due to a bloody tap, that this would then result in the internal controls and such within the panel itself not working, and the result itself or the test itself would just be voided or indeterminate. Otherwise, we have not identified any issues where we've had to avoid testing on the ME panel because of a bloody tap.
Thank you. And I'd like to close with one final question of my own for you, Dr. Dien Bard. You're at an academic children's hospital at a wonderful, wonderful institution with lots and lots of folks there to help and take care of your patients, and you have lots of resources, at least intellectually, if not always at your fingertips financially. But help me for a moment answer the question, what would you recommend to a colleague at a small community hospital who had all the same concerns about rapid diagnosis, effective treatment, good antibiotic stewardship? Would you have some final thoughts for those folks as they look at the ME panel?
I think that for the smaller community hospitals, do not, of course, take it lightly that this is still a molecular test, and to be really conscious of the risk of contaminations and such that can occur. So just to be very diligent. But on the other hand, this is, some of these type of panels, these sample to answer type of tests is a great opportunity for community hospitals that can afford it to really provide proper, good standard of care for their patients. We've had incidences where, we have a patient transferred to our hospital, the LP was performed there, and the HSV had to be sent out to a reference lab and wasn't going to be available for a few days. And it's just, it's really of concern that you can't even get an HSV result back within, 2 or 3 days. So with this panel, it really offers these smaller hospitals the opportunity to provide, key standard of care and, great standard of care actually to their patients. But of course, just to again emphasize the fact that it is molecular, not take it lightly. Just because it is easy to perform doesn't necessarily mean that you do not have to be very meticulous.
Yes, thank you. I would add that, to my knowledge, and I'll ask Wade to make a brief comment here, this technology is being very widely adapted in all kinds of sites, particularly in many, many community labs, at least that I'm aware of. Would you care to comment on that as well, Wade?
I would completely agree with that. As a matter of fact, in the last, I would say, 2 years, we've seen quite an increase of, I think since the launch of the meningitis panel, actually, we've seen quite an increase in adoption of the FilmArray system within the community hospital setting. So it's been quite impressive.
Very good. And I just wanted to raise one more question. A couple of people who are actually investigating the technology now are thinking about having staff wear a surgical mask during the setup to improve contamination problems. In other words, to avoid them. Is that something that you've experimented with, Jennifer, at the Children's Hospital?
We have not.
Cabinet. Okay.
We have not. Of course, if there was a staff member that has, visible signs of like rhinorrhea or such, then that may be something that we would ask, or actually they do put on a mask then for certain cases, but otherwise we have not had to implement that precaution.
Very good. Well, listen, I'm going to wrap up now. I would really like to thank BioFire and Wade Stevenson for their help today in helping us put this on through an educational grant. Above all, of course, I want to thank Dr. Dien Bard, who gave one of these wonderful, wonderful lectures and presentations for us. We couldn't do this without people like you, Jennifer, and we're deeply, deeply grateful. So I want to thank you for that.
Thank you.
I want to remind the audience that all the visual slides and audio will be available on captodayonline.com in about 5 to 7 days. And finally, I want to thank all of you in the audience for taking time out of your very busy schedule to listen to today's presentation. We do have a brief post-webinar survey, so please fill that out if you'd like to do so. But with that, I want to thank you once again, and we will close this webinar. Thanks again.